So good morning, everyone. Thanks for attending. It is an honor for me to moderate a journal club this month on an article that was published, available in February, a topic that's near and dear to my heart. Actually, one of the first areas of interest of mine as a fellow was residual sleep apnea and risk factors that are associated with this. And when I came across this article, I was delighted that we're now formalizing this field. So the article is entitled "Management of Persistent Post-Adenotonsillectomy Obstructive Sleep Apnea in Children." And it's my delight to have two friends who are panelists, Dr. Zarmina Ehsan from Kansas City School of Medicine and Dr. Stacey Ishman from the University of Wisconsin-Madison. These are this is, if you look at the authors, including Zarmina and Stacey, this is a very eclectic group of authors, which I think is what excites me most about this article. There were 13 international multidisciplinary experts ranging from otolaryngology, dentistry, sleep medicine, plastic surgery, and nursing, just highlighting how broad our field is in sleep. Considering that there are so many disciplines that are involved, it is really a coming of age where we are now bridging to others for assistance. And I think if you think about sleep apnea, this is such a fascinating disease where we are actually becoming very collaborative. The group of authors also, as part of a formation of guidelines, included a medical librarian, a methodology scholar, and a senior ATS methodologist. So the premise of these guidelines is largely related to what we've learned about sleep apnea, a condition in pediatrics that was first described in 1976. Early estimates of sleep apnea suggested the prevalence is about 2 to 3%. Some have now reported up to 10%, largely related to the obesity prevalence. I would say if you kind of think in between those two numbers, 5% of all children have sleep apnea is a good number. And what the authors highlight here is studies have shown that the first line of therapy, adenotonsillectomy, is successful at reducing the AHI, the marker of sleep apnea, but whether it is curative is certainly up for debate. And in fact, studies have suggested that about 40% of kids that undergo this surgery will have residual sleep apnea. So if you think about the numbers now, 2% of all these kids who have sleep apnea will have this condition called residual sleep apnea. And there are certainly risk factors. There's several that the authors describe. Some of the main ones that come across are having severe sleep apnea. Being obese is a risk factor for residual sleep apnea. And of course, certain syndromes, including Down syndrome, will be a risk factor for having residual sleep apnea following adenotonsillectomy. This is the first guidelines to really look at this condition, residual sleep apnea. That said, there has been two very important guidelines discussing management of sleep apnea and actually started to embark on what to do about persistent sleep apnea. And those guidelines were ones from the American Academy of Pediatrics that was pioneered by the late Carol Marcus. And then in 2015, there was a similar statement by the Pediatric Society of New Zealand. And in both of these statements, they kind of shed light on the fact that if you're going to have persistent sleep apnea following adenotonsillectomy, generally the knee-jerk is to recommend positive airway pressure for children. And while that was recommended, the reality is the evidence for this was low quality. And the authors bring up concerns that, well, positive airway pressure adherence in certain populations, including kids, might be low. There are potentially adverse events related to positive airway pressure, including if you think about a young growing child and you apply a mask, they are at risk for mid-face hypoplasia if they need to use this long term. And more interestingly, of recent times during the COVID pandemic, there was concerns that CPAP or other forms could actually aerosolize virus and cause infection. So the authors wanted to look more broadly and try to understand how we could better inform clinicians, patients, and other stakeholders about this real entity of persistent sleep apnea. Now, while they cipher through all the evidence, they realize that there's not really a blanket statement that this is really helping us guiding us in terms of what to do for these kids that have persistent or residual sleep apnea. Now, one thing that came across is we recognize that if you go through the literature, there are basically very different definitions of persistent sleep apnea. Most recently, we've been focusing on the AHI, even more specific, the obstructive AHI. If we think of obstructive AHI after surgery being 1 to 5 events, I think most would consider that as being mild OSA. There's certainly some evidence talking about using medications in this group, which is something that the authors discuss. But when you talk about like really perhaps clinically significant persistent sleep apnea, the authors thought that having an obstructive AHI greater than 5 events would probably be the definition with greatest consensus, partly because of the likelihood of sequelae, including neurocognitive sequelae. And certainly when we think about using CPAP or other modalities, we're tending to use this more often in cases where the residual obstructive AHI is greater than 5 events per hour. Now, in this guidelines, the target population, of course, were children and under the age of 18 that had to have had persistent OSA regardless of race, comorbidity, or any other demographic attributes. And so just kind of giving you a sense of the structure of how these guidelines came to be, the authors used the grade system to evaluate evidence, in addition to using the ATS policies and procedures. They were able to come up with 16 questions, but narrowed it down to 6, which we will go through today. They had a list of critical outcomes that they wanted to focus on. One, looking at cure or resolution of OSA based on obstructive AHI less than 1, improvement of OSA based on obstructive AHI less than 5. Other markers would include oxygen desaturation, quality of life measures, cognitive function, behavioral changes, and then any things related to weight. The authors, I really commend the authors for the amount of work they did in terms of scoping the literature and looking at different sources for evidence, including Medline, Embase, Scopus, Sinnel, and Cochrane. And as in all guidelines, the authors graded the evidence and basically would use sort of 2 criteria of whether to guide the reader. They would either recommend based on the quality of evidence, and if the evidence was not strong, the authors would then suggest. And so just before we go through those 6 questions, I will say that the take-home message from these guidelines is the authors recognize that there is not a lot of high-quality evidence for any of the recommendations for persistent OSA. And really, you will find that everything is a we suggest, not a we recommend. So every recommendation is conditional, and this is partly related to the certainty being very low based on the quality of the evidence. So I'm going to start with the first question, and the first of 6 questions that the guidelines posed. And that question was, should children with persistent sleep apnea be treated with CPAP? And the authors said, again, we suggest that children with persistent OSA who do not qualify for site-specific upper airway treatment may be considered candidates for treatment with CPAP. And this was a conditional recommendation. It was very low certainty in the estimates of the effect. And I want to begin with Dr. Ehsan about how the authors came up with this and where we are with using CPAP. So Dr. Ehsan, can you give us a sense of what we think where CPAP fits in this population?
Thank you so much, Rakesh, and welcome everyone. Thank you for attending. And Stacey, feel free to chime in as well, okay? So really the premise for this specific question was what we deal with on a day-to-day basis, thinking beyond the one-size-fits-all CPAP for all thought process. And as we see medically complex kids in our clinics who are obese, have craniofacial malformations, other genetic syndromes, thinking outside the box for what else they could be eligible for that is potentially curative for their sleep apnea. What else can they potentially get done? And also looking at CPAP as a treatment option, one of many treatment options. And so really challenging the paradigm with persistent OSA, so kids who have already had their adenoids and tonsils out, do they all need CPAP, or do we need to look at other options? So really the key points here are a collaborative approach, ideally working in a space where you have access to other subspecialists, a multidisciplinary team, and looking at these options and thinking about them if CPAP is either not desired or adherence is poor. And again, how we define adherence in pediatrics is also up for debate. Again, they sleep longer. And so some of this, at least in the US, is mandated by third-party payers, how we define the adherence. But in reality, they should be using CPAP as long as they're asleep. So if they're sleeping 10 hours, then ideally, as long as they're asleep, they should be using their CPAP. And so close monitoring for adherence. And if they're not adherent to CPAP, talking about next steps, evaluating the patient in the clinic, seeing if on exam you think they're eligible for some of those treatment modalities that we will be talking about. So for the CPAP question, really, we urge all providers, all physicians, APPs to look at regular adherence monitoring with downloading data. And again, the cadence of these visits vary depending on your practice. The current literature looks at the severity of OSA, improvement with CPAP, cognition, behavior, sleepiness, and school performance. We did not find any literature on mood and quality of life. And again, we know there are no randomized controlled trials at this point comparing CPAP or PAP, any PAP to no PAP. There are indeed barriers to CPAP adherence. There's more and more data about the impact on facial growth for those who are well adherent to CPAP. Again, if they're spending half of their day, if they're sleeping 12 to 14 hours a day, or even 10 hours a day, that's half of their 24-hour day almost. And so if they have good adherence, what impact is that pressure having, pressure from the mask having on their facial growth long term? Again, kids are growing, it's a period of facial growth at least until they're 15 or 16. And so keeping those into account is imperative. Stacey, do you have other thoughts?
Yeah, the one thing I think is really important is that this statement suggests very clearly that we don't think going straight to CPAP should be first line, even though in some places that is the sort of current paradigm. And by including the section where we say who are not candidates for site-specific surgery, we really suggest that these kids should be assessed for site-specific surgery. And it may be that we're comfortable doing that in our own offices. We may need to refer that patient to somebody who can do an evaluation that might include a clinic evaluation. There might be imaging evaluations. There might be drug-induced sleep endoscopy, and those are sort of included in this overall statement about how you might assess for those. But I do think it's really a departure, like you said, Zarmina, that we're not just saying go straight to CPAP. We recognize that probably some of the best care is happening in multidisciplinary clinics, which happen in lots of different centers. And so that's, I think all the things we're talking about here in terms of like standardizing CPAP are also really critical. But just the sort of the ultimate shift for recognizing like we need to actually make sure that people can evaluate these kids are doing this right off the bat.
So yeah, thanks, Stacey, for bringing that up, because actually one thing I was kind of curious by, because this was the first question asked, and did that mean this is the first line of therapy? And it obviously isn't based on what you're saying. But then when I read the statement, consider other approaches if CPAP's not desired, that makes sense, or adherence is poor. To me, that it came across as, okay, well, if they want to try CPAP, then try it, regardless of the endotype. And if it's not working for them, then consider the other approaches. Are you saying that we should probably pivot away from that to some degree, and maybe these kids should be seen in a collaborative multidisciplinary approach first to get an endotype, or where do you think we stand with that?
I mean, I think we're both gonna have an opinion, and we'll jump in,
Yeah.
but I'll just start first. I would think the opinion of the group was that we should be looking for site-specific options off the bat. So if somebody has, partial tonsillectomy and has large tonsils that come back, or they have big adenoids, or they have really obvious lingual tonsils, which take a little bit of investigation to find, that it's very reasonable for that to be first-line therapy instead of CPAP. I think your comment that goes to sort of like if it's not desired, comes to some shared decision making, right? We don't have really strong evidence for anything. I think you've just highlighted on your last slide. And so if there's a big piece of parental preference towards CPAP, towards surgery, like there's really an important conversation that has to happen about some of the desires based on the fact that we don't have really great literature in either regard. And so if I'm a parent who says, I really would rather just try CPAP, I don't want to consider surgery, we should try CPAP. If you say, I'd really rather look and see what my other options are and avoid CPAP, that's also a reasonable opinion. And so I think part of the reason that this isn't as straightforward is because the literature is not as straightforward.
Okay, great. Zarmina, did you want to add anything? Oh, can we get some folks muting their mics, please?
Thank you. I echo what Stacey, just mentioned as well. Again, shared decision making, looking at the resources that you have at your center as well. If it's going to take 6 months to get into CENT, then do I start CPAP now for this child with severe OSA while they wait to get evaluated? So I think some of this just depends on your practice, and what you have available to you. But again, thinking about these things off the bat when you're reading those sleep studies or getting those reports, putting everything together with the patient, again, personalizing care for them. They have, you think they're at risk of having surgical sites of airway obstruction, thinking of those options or thinking of pursuing those while you also talk about CPAP, and presenting the family with all those options is what we felt would be, would be ideal.
And keep in mind the CPAP recall happened right in the middle of us going through this too. So what seems like a super easy option, and probably in the adult world seems easier to do these days, became a really hard option in the pediatric world. So getting a new patient on CPAP wasn't as easy as just showing up in clinic and starting CPAP. Like we were more available than CPAPs were. And so that's the other thing to keep in mind. I love the conversation about resource in your settings, Zarmina, because that was happening in the midst of this conversation too.
Okay, great. So let's go on to the second question and recommendation. So question 2, should children with persistent OSA undergo orthodontic or dentofacial orthopedic treatment? And the authors, again, we suggest that children with persistent OSA with specific craniofacial features may be considered candidates for orthodontic dentofacial orthopedic treatment. Again, this was a conditional recommendation based on very low certainty in the estimates of the effect. And again, I'm going to bring in Zarmina for this one to kind of give us a sense of how this recommendation came to be.
So, this recommendation, again, we had thought about the comorbidities that we see frequently with persistent obstructive sleep apnea, and so part of all those, this came up as well as a modality that is offered, and again. These are patients on examination where you see a constricted maxilla or a constricted palate or a high arched narrow palate, and our group felt that if you are seeing that on exam, recognizing that on exam, or if they have seen a dentist, an orthodontist, and been referred to you for the sleep study aspect of it, then this is something that can be offered to them. Again, this depends on what resources are available to you at your center. At least within the US, these are out of pocket, so not covered by insurance, and are typically expensive. And so really talking to the family, again, coming back to shared decision making for these specific patients is what we recommend. Stacey, do you have other thoughts?
No, I think that captures it. And again, this comes back to lack of literature, right? Like, so there was lots of opinions in the room, but where was the evidence?
And so one question I was going to ask you guys, I mean, you had a group of dentists as collaborators here. How often are these treatments really happening without the guidance of, sleep studies or sleep specialists? Yeah, just kind of empirically using this modality. Sometimes I've seen it even before tonsillectomy, but certainly I will see it a lot after tonsillectomy. And did they kind of give you a sense as to the formalization of their decision making with regards to, seeing them in the dental clinic without access to a sleep center?
I don't think we had very significant conversations about that in terms of how often it's happening pre or post
Yeah.
and tonsillectomy. I would say there's lots of people, for as many people as maybe getting some of this done without sleep evidence. There's lots of places where people want their patients to undergo this procedure and can't get access to providers who are going to take care of kids, perhaps with public insurance and some other things. So there's probably conversations in both directions on whether we're over and underutilizing
Okay.
modalities like this. I can tell you in many of the markets I've worked in, I've had a hard time getting anybody to do this, especially in younger children. So, Zarmina, feel free to jump in if you got a different flavor for that.
Okay. There's a question in the chat. Which proportion of children do you think would meet the criteria for orthodontic treatment regardless of cost?
I look in the palate in all the kids I look at, and also keep in mind, right? Like we're looking for a high arch palate with almost no criteria, right? That's just what is
Sure.
Stacey Ishman think is a high arch palate. But I would say it's the significant minority of my patients. I think we're talking like the 5 to 10% of otherwise healthy patients. Then you start talking about craniofacial patients and that number soars. So I don't actually think I'm seeing a giant number of kids that probably need to go there, but probably up to 10% of the kids who are otherwise healthy, and then lots of the syndromic kids. Zarmina, what are you seeing in your clinic?
I agree with you, Stacey. Again, no published numbers, but I think it's within that ballpark. Again, it depends on your practice. So when I do my multidisciplinary craniofacial clinic, we have a very high percentage of kids who are eligible for this. Again, they're being referred for this. And so I think some of this will vary depending on your referral patterns and so forth.
Yeah, and the other thing I was always wondering, I guess I'm biased in my clinic because I'll see these kids, and they're more likely to have a palate expander or a history of palate expansion at some point in their life. And one thing like I can never come to grips with, and I don't know if my issue is sort of the referral bias, but are we seeing a rise in palate expansion? And there's also this idea of it being preventative. And I don't know if these questions have been formally addressed. I know they've looked at it in the context of residual sleep apnea, which we're focusing on. But just in terms of the question about proportion, I get the sense that we're seeing more of these kids having this. Are you guys seeing that as well, or am I sort of in left field?
I am not. I would actually
Okay.
tell you I'm in one of those places where I feel like I'm not able to access it as easily. So this is sort of that whole question about where you practice and
Yeah.
resources. I would say we obviously didn't address things like prevention because we're talking about persistent sleep apnea. But worst case, we're giving them a better nasal airway from an ENT perspective. So some of it probably depends on what you think you're treating, whether it's nasal breathing, whether it's snoring. But I think honestly, like almost in every area, we have some places that are overutilizers and underutilizers. And what I would implore people is if you're in an area where they're overutilizers, get people to write up their experience. Try and get them to study it in some useful way because the evidence that we looked at for this particular statement was really limited.
Okay. Great. All right. I'm going to move to the third question. And sorry, I'm not trying to pick on you, Zarmina. I will have Stacey moderate the next couple of slides. But question 3 is, should children with obesity and persistent OSA undergo weight loss intervention? And the author's statement was, we suggest that children with obesity and persistent OSA undergo weight loss intervention. Conditional recommendation, very low certainty in the estimates of the effect. And again, Zarmina, can you give us a sense as to this recommendation?
Thank you, Rakesh. So again, for anybody who manages and sees patients with obstructive sleep apnea, obesity is a comorbid medical condition that increases your risk of severe OSA and persistent OSA. So I think answering this question, there was consensus amongst the group that this was a key question to answer. We couldn't find any studies specifically on persistent OSA, but we felt that regardless of whether you have your tonsils or not, the modalities to help lose weight are the same, and so would be equally as effective either way. And so the panel felt that weight loss interventions, so medical weight loss interventions, are key to look into those, and if it's not successfully achieved, then consider surgical weight loss for children who are eligible.
And Stacey, did you want to add anything to that, or?
No, I mean, we had a long debate on whether the literature for all kids was relevant to kids who had persistent versus primary sleep apnea. And clearly we had a strong opinion with the group that we thought they were relevant. But that's sort of the big proof is in the pudding, is people have to decide if they agree with that statement, because that's the underlying assumption for the statement.
And it would be wrong of me not to ask, based on the news yesterday of Eli Lilly's approval of tirzepatide in the space of sleep apnea treatment for adults, that they have FDA approval. Was this at all discussed with the new medications used? Would this ever enter the space for pediatrics? I know this was not part of the recommendation, but I just out of straight curiosity.
So, I mean, I don't remember us talking about the meds. Do you?
Not specifically, no.
Okay. Okay, great. And then now we'll shift to Dr. Ishman. So the next question was, should children with lingual tonsillar hypertrophy and persistent sleep apnea undergo lingual tonsillectomy? And the statement reads, we suggest, again, that children with lingual tonsillar hypertrophy and persistent OSA may be considered candidates for lingual tonsillectomy. Again, this was a conditional recommendation with very low certainty in the estimates of the effect. So Stacey, give us a sense of where do you think lingual tonsillectomy now plays in this population?
So the conversation around this particular one was interesting because I think people actually wanted to have a higher level of recommendation, but it just wasn't supported by the literature. So the people in the room felt like lingual tonsillectomy in kids with large lingual tonsils could be very effective. But again, we're limited by what's been published, and a number of the studies had mixed populations. They weren't all persistent sleep apnea, and they weren't even all just done for sleep apnea. So the key too was to look for large lingual tonsils, identify this. And this brings us back to that first statement, right? For looking at people who had site-specific areas that you might want to consider treatment for. And then we all know that there's some groups that are high risk for large lingual tonsils, especially children with Down syndrome. There's a study showing about a third of them have large lingual tonsils that's identified in kids with residual disease. And there's a number of ways to look for them. You can look in an office scope. You can do it on drug-induced sleep endoscopy. For the small number of places using cine MRI, it's really easily identified. The one caveat I would throw out there is it can be a little over-identified in drug-induced sleep endoscopy. It's hard to tell a large base of tongue from lingual tonsil hypertrophy, and I haven't published it yet, but we have compared our cine MRI experience to our DICE experience and found we probably overcall it a little bit on just DICE. But you can see when you look below that there was 8 studies, and what they reported is not consistent. And so that's one of the biggest problems in our literature, is probably coming up with a standard reporting structure. Improvement in the AHI was reported in the majority of studies. Most of them got to the mild range, but most of them didn't get to the complete resolution range. And you can see only 20% reported complete resolution. And so some of it depends on how much you feel you need to treat asymptomatic kids with mild sleep apnea. And so that is not addressed by this particular guideline. But that was one of the comments made here, is that a large number of those kids get to sort of the mild range. And then there were some concerns about negative consequences, almost all of which were on the same ballpark of incidence as we see with tonsillectomy and adenoidectomy, which I think as a specialty and as the multiple specialties, we feel comfortable offering for primary sleep apnea. So The risk from the lingual tonsil hypertrophy surgeries were no more than tonsillectomy and adenoidectomy. And that part I think people felt pretty comfortable with. I mean, then again, outcomes, just like everything else, were very limited beyond things like sleep apnea and sleep study parameters.
Zarmina, did you want to add?
Nothing more than just to say, as a non-surgeon, again, I rely on other surgical specialties or imaging when I see patients that are suspected for this. So I will look at comorbidities and then decide on referral based on that.
And so what I want to, I guess, ask Stacey, I mean, I know there's sort of some inconsistencies about getting a grading for lingual tonsillar hypertrophy. Certainly, if there is a risk factor like Down syndrome, we're probably going to look for it more often. But even in the kids that don't have Down syndrome, I mean, the typical sleep specialist or pulmonologist will not grade lingual tonsils when we examine these kids. Is this relevant, or sure, let me rephrase it. Is this lingual tonsillar hypertrophy highly prevalent enough that we should be, as part of the endotype for any child that does not have Down syndrome, that they get graded for the concerns that they may have persistent sleep apnea following adenotonsillectomy?
So I'm assuming you're talking on a bronchoscopy or a DICE?
Yeah. During even like intraoperative, if you
Yeah.
have a kid send off for tonsillectomy, I mean, then you have the luxury of looking at lingual tonsils. And so I'm wondering, should we be doing this for all comers that are undergoing the surgery?
If we just wanted to do something simple, we could probably talk about whether you can see any of the base of tongue vallecula or not.
Okay.
So I would suggest we probably all should be looking at this, especially in kids with sleep apnea. But you don't have to get fancy with the grading scale, although there's a couple out there.
Yeah.
One by Norm Friedman, one by Michael Friedman. But I would actually say if you just can identify whether or not they've effaced or filled the entire lingual vallecula, that's probably enough. So if it's filling that space, it's probably enough for someone to do some further evaluation. If it's not filling that space, it probably suggests that lingual tonsils are not going to be a major issue. And I think you could probably boil it down to as simple as that.
Okay, great. Thank you. All right, I will move on to the next question. Should children with obstruction at the supraglottis and persistent sleep apnea undergo supraglottoplasty? Statement reads, we suggest that children with sleep-dependent laryngomalacia and persistent OSA may be considered candidates for supraglottoplasty. Again, conditional recommendation, very low certainty in the estimates of the effect. And again, I'll ask Stacey to give us some clarification for this recommendation.
So we were specifically looking at that group of kids, not the congenital kids who also have sleep apnea, but more the sleep-induced laryngomalacia in the older kids. And so that was one of the conversations we had. There's actually pretty good data that congenital laryngomalacia, when you do supraglottoplasty, gives you significant resolution. In the kids with sleep state dependent, there's not as much literature. But when we looked at the literature was out there, it actually suggested the OAHI has resolution in at least about 2/3 of the kids. And that literature is summarized in the guideline. And here looks like you have a picture of ways that you can have laryngomalacia. So there's all kinds of different options here.
Yep.
There's lots of red things that look like they're probably able to collapse in is what I think is being assigned here. But most commonly, the area epiglottic folds are falling in. And that's usually what we're talking about supraglottoplasty for. Or an aretinoid may be flopping completely into the airway. I've actually seen people where they flop through the airway. And they can be very, very useful. One thing to keep in mind when you're looking at supraglottic collapse on your DICE or your bronch is if there is upstream obstruction, sometimes we will see this in conjunction with something else like lingual tonsil hypertrophy. And so you'll probably want to keep that in context. But we did feel like this is a group where we can do some significant benefit. If you read, there were some concerns about feeding or swallowing issues after supraglottoplasty, just as there are when we do this in younger kids. And the supposition at the end was that unless kids had pre-existing issues or were syndromic, probably the otherwise typical child, there's no significant concern about new onset dysphagia. Some transient dysphagia has been shown in some of these kids. And so in kids with swallowing issues, this is probably an important conversation if you're going to consider this procedure. And just like these others that we've talked about, really no significant literature that looks at mood or cognitive function or behavioral changes.
And so, sorry, Zarmina, did you want to add before I ask the question here? So I wanted to ask Stacey, I mean, you know, this is, you may get guided with doing a flex in the office, a flexible laryngoscope, but often the decision can often happen with DICE, from my understanding, especially if this is like sleep-dependent laryngomalacia.
Yeah, oftentimes they won't have any laryngomalacia in the office, but you will sit on a DICE or a bronch. And so this is a little bit different group than that congenital group of kids who you'll be able to identify daytime or nighttime.
And so I know there was discussions about sort of DICE in these guidelines, but you know it seems that at least with both the recommendation 5 and 6, DICE is pretty critical for some of these decisions. But we're not doing DICE on every child after they have tonsillectomy necessarily. Again, where you know, if you talk about the clinician that doesn't do DICE or doesn't, you know, have a flexible laryngoscope in their office, you know, how can we be guided here for those of us that don't have these tools in our office?
To be totally honest, this particular condition you can't diagnose without DICE or
without DICE, right?
And I will tell you that I worked at Cincinnati for 10 years, and it was our practice to talk about DICE with everybody who had persistent sleep apnea that was at least moderate, which is the group that's being discussed here. It doesn't mean we did DICE on every single patient, but we talked about the value of considering it with families. And so this comes back to some of that shared decision making. If parents want to consider surgical options and we think there's reason to, it's probably reasonable to offer it. The other thing is the group who I think are more likely to have sleep-dependent laryngomalacia are kids who had laryngomalacia as infants, or if parents hear stridor at night. Now, with that said, I don't get a lot of people with those histories. And I will also tell you that most of the people I diagnose with this condition have neither of those things in their history. But those are higher yield for you to think about it. So if you're just working on a history perspective, asking those questions can be useful in the office.
And then the last question I want to ask, again, for both recommendations 5 and 6, I mean, we're talking about persistent OSA following tonsillectomy. We have some sense of which population is going to have persistent OSA. Well, we also recognize that there are going to be persistent OSA following these airway surgeries, lingual tonsillectomy or supraglottoplasty. Where are we in terms of getting a sense of which risk factor or what the risk factors are for residual OSA in these populations from secondary surgeries? Do we know enough? Are we confident that it's going to be curative?
So now you're in the Wild West. Like there's enough time.
I am in the Wild West. I live in San Diego, so
yeah. Well, so metaphorically and physically. So I'll tell you that what we spent most of our time doing was looking at AHI changes. And so in this particular group, the range was somewhere in the 50 to 70% range, depending on what study you looked at. And there was at least one meta-analysis we looked at. But so we're talking about of the 40% who maybe still had it. And quite honestly, that 40% is probably really, really balanced towards the syndromic kids. So I think there's two different groups. Otherwise, healthy kids, probably 20% have residual disease. And then these are probably the groups that are more likely to be in the 50 to 70% range with a supraglottoplasty or a lingual tonsillectomy. So maybe our residual numbers are somewhere in the 30 to 40% again, which takes us from 40 down to 12, 15. But then if you get into those syndromic kids where we said, gosh, maybe 60% of kids with obesity actually have residual disease, and the effectiveness here may be more like a third. Now we're still talking about 40% of these kids who may still have some issues. So I think the part of what we really need to do going forward is figuring out how to subgroup. So you talked about endotyping, you talked about phenotyping. I think those things are going to be where we have to work going forward to give better answers. But if Zarmina has figured it out better than I do, or has other ways of looking at it, please jump in.
And I think Iris is going to ask a question, but I just want to ask one follow-up question on that, Stacey. What about age? Like, I mean, I know in tonsillectomy, I'm not very convinced that this is the be-all, end-all for adolescents, right? I think it may be the younger kids, but I'm starting to think maybe we shouldn't be wasting our time with the older kids, the 16, 17, which is largely driven by obesity. I get that, but what about age here? Are these surgeries successful in older kids?
So even in adults, tonsillectomy is effective in 50% of kids. So we're not talking about persistent sleep apnea right now. We're talking about
like
they
improving.
are going to have persistent sleep apnea.
Yeah.
So I would say I actually do think it's worth it.
Okay.
The obesity factor makes everything different, right? You tend to think of older teens, probably more like adults. And once you start hitting obesity, reducing weight or the BMI, which is, as Zarmina had talked about earlier, I think becomes sort of almost primary for some of those kids. Doesn't mean that you're not going to get some benefit from getting big tonsils out, but if you don't address the obesity, we're probably not going to win the war.
Okay. Good.
And Zarmina, what are your thoughts in terms of integrating that obesity part?
I agree with, that's kind of a variable that impacts all of these things. So surgical success and CPAP success and so forth. I think coming to your question, Rakesh, about, surgical success for these, what we don't know is, if you have sleep-dependent laryngomalacia, very severe sleep-dependent laryngomalacia, severe OSA, is treating this, even though we don't cure or resolve the OSA, if the AHI improves or your metrics of sleep apnea severity improve, does your adherence change? Again, we don't know those things. So if you get rid of large lingual tonsils, does that mean, or, we didn't talk about nasal surgery, but some of those surgical sites of obstruction, if they are removed, how does that impact CPAP adherence? And if you're going to come to CPAP anyway, is it worthwhile doing these surgeries to see where you land? If your AHI is, say, 50 when you start, I think it is worthwhile to, if they're eligible, to actually do these and see where you land at the end of it.
Sounds like a part 2 for this guidelines. Iris, I saw you put it in the chat, but you don't want to just ask your question through Zoom?
To ask, if DICE is performed during the primary surgery, would that predict persistent OSA? I don't know if that was discussed.
No, it wasn't discussed as much, but there is a DICE consensus statement that was done by the American Academy of Otolaryngology, and I happened to be on that one also, and so was Zarmina, actually. And we really agreed that there was enough change after you took out tonsils and adenoids that probably the aerodynamics is going to be significantly different, but it might be useful to show you things like large lingual tonsils that exist at the time of tonsil and adenoid surgery. And I also think it's interesting to see if there's some supraglottic collapse at that same time, and see if that might be a future target. Anne Budwin's was actually on this guideline and on at least one of the others, as well as a number in Europe. And her data has shown that even when you see some of that supraglottic collapse at the time of prior to TNA, almost all those kids still had resolution of sleep apnea without doing anything like supraglottoplasty, but just doing the adenotonsillectomy. So I think there's enough differences in airway dynamics that happen after the tonsils come out that unless you're just looking at like large anatomy, like there's big lingual tonsils, I wouldn't put all of my confidence in using that by itself.
That's helpful. Okay, just in the interest of time, we're going to go for the last recommendation. Again, I'll go back to Zarmina. So this question is, should children on intranasal steroids with persistent sleep apnea after tonsillectomy be treated, adenotonsillectomy be treated with montelukast? The statement reads, we suggest that children on intranasal steroids with persistent OSA may be treated with montelukast. Again, a conditional recommendation with very low certainty. And Zarmina, tell us where you guys stood with this medical management and why this recommendation was made.
Thank you, Rakesh. So this, again, we're talking about moderate to severe, or at least moderate obstructive sleep apnea after getting your adenoids and tonsils out, and specifically for those patients who are not eligible for surgery, are not wearing their CPAP. So where are you now? Where or surgery has failed, or they still have persistent disease after surgery, and so that's where this specific question came, and we wanted to answer the question about montelukast specifically, given within the U.S. at least the black box warning with mental health concerns following the use of this. So and so again, without robust data, there was only one small observational study looking at this population, but we did see that it can show improvement. And again, for using this combination, our group felt making sure we are following for behavior and mood related changes should those occur, and also looking at cost and seeing if this is, what the cost is for the family, and again, shared decision making at that point. Stacey, do you have thoughts?
Just that this is probably the one recommendation we also thought probably applies to mild sleep apnea, because the studies really are in kids with AHI between 1 and 5 for the most part, although there are some looking at moderate.
And I was going to ask, some of the pathophysiology is largely driven by allergy, and there certainly is a context here for these medications if you have, allergic rhinitis or propensity for allergies. Is there a time and place that we think about allergy testing to phenotype these patients to go down this pathway?
I mean, that was definitely not covered in the recommendation, just to be clear. So I'm happy to give a thought.
Okay, yeah, no,
Not be about the
do.
guideline.
Yeah, no, please do. I know that this is a tangent, but please do, Stacey and Zarmina.
Yeah. So I mean, I actually think the use of montelukast also includes conversations about asthma, because so many times we're trying to make sure that we're optimizing care across the patient and not just for a single disease process. And I am happy not to be somebody who treats asthma as an otolaryngologist and sleep physician. So but I do think looking at allergy and doing allergy testing can be really, really useful, especially if you're in the more mild range. I think it's useful for lots of kids. I don't think when we talk about the moderate to severe range that we think it has quite as big of an impact, based on the fact that we don't think nasal surgery even by itself, like let's say, not just, making your allergies better, but making your turbinate smaller in general, probably doesn't cause a huge impact. The one adult meta-analysis out there suggests you can improve about 11 events an hour, which in the adult world they were wildly unenthusiastic about and only included 2 studies. So just to be clear, it's not a great study. And I co-wrote it, so I know it's not a great study. But I will say that I think in kids we feel like some improvement of mild nasal symptoms or major nasal symptoms improves mild sleep apnea. So I think it has a great impact in the mild range, maybe in the moderate range. And I think once you start to get to severe sleep apnea, the role is a little less. But Zarmina, how do you use it?
I agree. So same thoughts. And Rakesh, I agree. We didn't look into allergies or allergy testing within the guideline, but I think that's a great point to consider that and really hone in on that history when you're seeing these kids.
Yeah, and it's partly based on these are finite treatment durations, right? But sometimes these kids can't come off these treatments, and you find out after that they're having their symptoms again. And then just kind of going back to Zarmina, what you brought up earlier, sometimes we do these things to optimize CPAP adherence. And I know when you have large turbinates, or if you have a lot of allergic rhinitis, it makes CPAP very difficult. Did you guys talk about these approaches in that context?
No.
No, okay.
But
okay.
I totally agree that they help with CPAP adherence.
All right. So I'm going to conclude and I'll open up for questions. But first, many thanks to Zarmina and Stacey and the other authors who've put together, I think, a very informative guidelines. And it really sheds light on this growing population of kids that have persistent OSA that we're kind of stuck with. And so the authors concluded that persistent sleep apnea should personalize treatment decisions based on symptoms, benefits versus risks, medical comorbidity as suggested by what was recommended. But in the future, we need to really improve the quality of the evidence by using head-to-head randomized control trials, including looking at other, I think, very important factors, including like social determinants of health, such as race, economic status. And then the authors do mention that there are even more novel treatments that were not discussed, but certainly will probably be discussed in part 2. And I'm hoping they will do part 2. But maxillomandibular surgery, hypoglossal nerve stimulation, which has now been approved for Down syndrome over the age of 13, high flow nasal cannula, and myofunctional approaches. And I also mentioned the GLP agonist, which just yesterday was approved for sleep apnea in adults. Again, thank you to you both, and thank you to the authors for putting together some really informative guidelines. And I want to just open up the last 5 minutes to anybody that had any questions.
While we wait in the chat, I do want to mention here that we were limited to 6 questions just based on
Okay.
ATS rules. And so we actually had 2 craniofacial surgeons on our panel because when we applied for this guideline, we did want to answer the question about maxillomandibular surgery. So we had them on our panel, but then we had to limit to 6, and we really fought hard for that 7th question. But we couldn't get so just all this to say, it doesn't mean that some of these other modalities aren't as important in pediatrics, but just we were limited ATS rules, and so that's kind of where we were with just the 6 questions.
Thanks for that clarification, Zarmina. I was wondering why you didn't want to write more. Especially because you had a newborn at that time of preparing these guidelines. So
yes, when we were revising them, yes.
All right. Are there any other questions for the panelists?
This is great. Thank you.
Okay, well, many thanks everyone for your participation. Again, thank you, Stacey and Zarmina, for really advancing our field in this population that's growing. So I think we're getting a little clearer picture for these kids.
Fantastic.
And I'll see you all in San Diego, hopefully.
Thank you.
Thank
All right,
you.
thanks, guys. Bye-bye.
Okay, I'm running to the OR. Thank you, guys.
Okay, bye. Thanks, Stacey.
Bye.